Welcome to our second and last video on congenital mixed immunodeficiencies. Let's begin. In this lecture, we will go over Hyper-IgM syndrome and Ataxia-Telangiectasia. For each topic mentioned, we will go over definition, pathophysiology, risk factors, clinical features, diagnosis, and management. Hyper-IgM syndrome is a primary immunodeficiency disorder characterized by elevated levels of IgM and diminished levels of all other immunoglobulins. The pathophysiology of Hyper-IgM syndrome stems from an X-linked recessive mutation that causes a deficiency of CD40 ligand that is found on T cells. At its core, CD40 ligand has two primary purposes. It is necessary for class switching of B cells, and it is necessary for formation of memory B cells, which in turn are necessary for formation of a long-term immune response. Let's utilize this illustration to explore the pathophysiology of Hyper-IgM syndrome a little further. By default, all B cells are equipped to produce IgM, so you can think of IgM as the default immunoglobulin. During a process known as class switching, a T cell interacts with a B cell to instruct it on whether to stick to production of IgM or to change its class and start producing a different type of immunoglobulin, such as IgG or IgA. This interaction relies on a connection between the CD40 receptor on a B cell and the CD40 ligand on a T cell. Once class switching takes place and the B cell knows which immunoglobulin it needs to produce, it divides to form a memory B cell to maintain long-term immunity and a plasma cell to start producing its class of immunoglobulin right away. In patients with Hyper-IgM syndrome, however, this whole process is interrupted due to a deficiency of CD40 ligand. Without the CD40 ligand, class switching cannot take place, memory B cells cannot form, and the patient's B cells are permanently stuck producing IgM, which leads to an immunodeficiency. The primary risk factor for Hyper-IgM syndrome is male sex, since this condition is inherited in an X-linked recessive pattern. When it comes to the clinical features, Hyper-IgM syndrome presents early in infancy. Patients start having recurrent sinopulmonary infections such as otitis media or pneumonia. Since these patients cannot produce IgG to opsonize pathogens, they have an increased susceptibility to encapsulated organisms such as Streptococcus pneumonia. Furthermore, since their T cells cannot properly interact with antigen-presenting cells, these patients also have an increased susceptibility to opportunistic infections such as pneumocystis jirovecii. All these recurrent infections eventually result in a failure to thrive. Lastly, patients with Hyper-IgM syndrome also have scant or even absent lymph tissue on physical exam, meaning that these patients may have absent tonsils or lymph nodes. The diagnosis is usually first suggested by quantitative serum immunoglobulin measurement. As the name of the disorder suggests, will reveal elevated levels of IgM and decreased levels of IgG, IgA, and IgE. Clinicians may then order flow cytometry, which will reveal an absence of CD40 ligand on lymphocytes. Finally, clinicians may rely on genetic testing to definitively establish a diagnosis of Hyper-IgM syndrome. As far as management is concerned, patients with Hyper-IgM syndrome are managed with intravenous immunoglobulin therapy to replenish the missing immunoglobulins and periodic antibiotic prophylaxis to mitigate at least some of the recurrent infections that these patients experience. Will patients with Hyper-IgM syndrome benefit from immunizations? Pause the video and take a moment to consider this question. Will patients with Hyper-IgM syndrome benefit from immunizations? The answer is no. Patients with Hyper-IgM syndrome will not benefit. This is because these patients have impaired production of immunoglobulins and memory B cells, which prevent them from mounting an adequate immune response to immunizations and during subsequent exposures to the antigens in the vaccine. Let's move on to discuss the last topic in this lecture, Ataxia-Telangiectasia. Ataxia-Telangiectasia is a primary immunodeficiency syndrome that impairs both B and T cells. It is also known as Lewy-Body syndrome. The pathophysiology of this disorder stems from an autosomal recessive mutation in the ATM gene that disrupts the normal DNA repair process. As a result, DNA damage accumulates in lymphocytes, eventually leading to their death. The primary risk factor for this condition is a positive family history due to its autosomal recessive inheritance pattern. As the name of the disorder suggests, the two primary clinical features of Ataxia-Telangiectasia are ataxia and telangiectasia. Notably, ataxia occurs due to progressive cerebellar atrophy seen in this disorder, and telangiectasias can manifest not just on skin, but also on the eyes. The other common clinical features include abnormal eye movements, in part due to cerebellar atrophy, recurrent sinopulmonary infections, such as otitis media or pneumonia, and increased risk for cancer, most commonly lymphoma or leukemia. The increased risk for cancer should make intuitive sense because these patients can't repair DNA as well as the people in the general population. Lastly, patients with Ataxia-Telangiectasia also have scant or even absent lymph tissue on physical exam, which occurs as a result of general lymphopenia. Here's an image depicting ocular telangiectasias. Note the characteristic spiderweb-like dilated blood vessels on the patient's sclera. And here's an example of telangiectasias on the skin, in this case on the person's left ear. When it comes to the diagnosis of Ataxia-Telangiectasia, laboratory evaluation will reveal elevated levels of alpha-fetoprotein, or AFP, and decreased levels of IgG and IgA. It isn't entirely clear why these patients have high AFP and decreased IgG and IgA, but it seems to be a consistent pattern from one patient with Ataxia-Telangiectasia to another. Once the suspicion for the disorder is high, clinicians may order genetic testing to confirm the diagnosis. As far as management goes, it largely revolves around supportive therapy, such as physical therapy to help patients deal with ataxia. Clinicians may also consider using intravenous immunoglobulin therapy and periodic antibiotic prophylaxis to help mitigate the recurrent infections that these patients experience. Lastly, clinicians should discuss a cancer surveillance strategy with all patients, as these patients are at higher risk for developing a malignancy. Proper cancer surveillance can ensure early detection and improved odds of survival. Here's a table summarizing the most salient and high-yield concepts discussed in this lecture. You may find it useful to return to this table when reviewing the congenital mixed immunodeficiencies before your exams. Let's conclude this lecture with a multiple-choice question. A 2-year-old girl is brought to the emergency department by her mother due to a high fever and labored breathing. Her mother says her daughter's symptoms started earlier today. The girl's past medical history is notable for recurrent sinus and ear infections, and she had a recent hospitalization for pneumonia. Blood pressure is 105/72, pulse is 95, temperature is 39 degrees Celsius, and physical exam is notable for diffuse crackles throughout both lungs. Lymph nodes are not palpable. Several small dilated tortuous blood vessels are notable on the patient's sclera and skin. Initial lab evaluation is notable for lymphopenia. A chest x-ray reveals bilateral ground glass opacities, and a tracheal aspirate is positive for pneumocystis jirovecii. Which of the following underlying mechanisms is the likely cause of this patient's recurrent infections? A. Impaired class switching. B. Deficiency of CD40 ligand. C. Mutation in the WS gene. D. Mutation in the ATM gene. The correct answer is D. Mutation in the ATM gene. This is a case of a 2-year-old girl with a likely underlying primary immunodeficiency. This is suggested by her recurrent sinus and ear infections, a recent hospitalization for pneumonia, non-palpable lymph nodes on physical exam, lymphopenia on lab evaluation, and a tracheal aspirate positive for pneumocystis jirovecii, which is an opportunistic pathogen. The key to the correct answer in this question is noting the presence of several small dilated tortuous blood vessels on the patient's sclera and skin. This is a classic description of telangiectasias, and the presence of telangiectasias in the context of a likely primary immunodeficiency syndrome is strongly suggestive of Ataxia-Telangiectasia as the underlying cause of the girl's recurrent infections. Recall from this slide that, among other things, patients with Ataxia-Telangiectasia usually have telangiectasias on the skin and eyes, recurrent sinopulmonary infections, and a scant lymph tissue on physical exam, which is consistent with the clinical picture of our patient in question. Then recall from this slide that Ataxia-Telangiectasia is caused by an autosomal recessive mutation in the ATM gene. This is why option D, mutation in the ATM gene, is a correct answer. Option A, impaired class switching, and option B, deficiency of CD40 ligand, are both features of Hyper-IgM syndrome. Since Hyper-IgM syndrome does not present with telangiectasias, these options are less likely than option D. Lastly, option C, mutation in the WS gene, is a feature of Wiskott-Aldrich syndrome, which is characterized by a triad of recurrent infections, microthrombocytopenia, and eczema. Telangiectasias are uncommon in Wiskott-Aldrich syndrome, which is why option C is not the right answer. And this concludes our lecture on Hyper-IgM syndrome and Ataxia-Telangiectasia.